Welcome to Medical Corner. Today we are going to start the next very important topic of special heart pathology, which is rheumatic heart disease. To understand the concept of rheumatic heart disease, first we have to clear the concept of rheumatic fever. So what is rheumatic fever? It is a systemic post-streptococcal non-suppurative inflammatory disease. So it is a systemic disease. So systemic diseases affects multiple organs, more than one organs. So in rheumatic fever, the organs which are most commonly affected are heart, joints, central nervous system, and most often and most commonly it can affect our skin. So, according to the William Boyd dictum that rheumatism licks the joint but bites the whole heart. This disease starts with joints problem, and at the end, at its chronic stage, it can affect the activity of the whole heart. So, moving on to its incidence, rheumatic heart disease or rheumatic fever is most common in children, and the age of the children may range from 5 to 10 years. And the rheumatic heart disease can caused by streptococcal frequent infections. And the second most common incidence of rheumatic heart disease is due to the poor socio-economic strata of the community or the peoples, and the incidence can also be increases in overcrowded and in developing countries. So if we move on to its etiology, the most common etiological factors which are responsible for rheumatic heart disease, these are environmental factors, number one. Number two is host susceptibility, and number three is immunological evidences. So in a nutshell, the rheumatic heart disease, the damage which is caused is not by the infection, but the damage is caused by the hypersensitivity reaction. We talk in detail about it later on. So the agent which cause rheumatic heart disease or rheumatic fever is streptococcus pyogenes. Streptococcus pyogenes, it is a gram-positive bacteria, and according to the last field classification, it is group A beta hemolytic streptococcus. And the rheumatic fever or the problem begins with the streptococcal pharyngitis, and the incidence of rheumatic heart disease or the probability of rheumatic heart disease is less than 3% of cases which progresses to the rheumatic heart disease. So this is all about the introduction of rheumatic heart disease. Now we move on to its etiology. So now we are going to start with the etiological factors of rheumatic heart disease. So an etiological factor, the number one is environmental factors. So there are various environmental factors which can contribute towards the development of rheumatic heart disease. So the number one is any history of previous infection, and in the most cases of strep throat and in the most cases of rheumatic heart disease, there is prior infection of streptococcus pyogenes, 2 to 3 weeks prior infection of streptococcus pyogenes. So second thing is recurrent infections, as the children are more prone towards the bacterial infections, and recurrent infections of the streptococci can lead to the rheumatic heart disease. Third one is socio-economic factors. The incidence of rheumatic heart disease increases in poverty and the places where there is overcrowding of the peoples. Number four is geographic distribution. The incidence of rheumatic heart disease increases in the developing countries, and there is less reported cases of rheumatic heart disease and rheumatic fever in the developed countries. And the last one is role of climate. The wet and the areas near the rivers are more prone to the rheumatic fever and rheumatic heart disease. So the second one is host susceptibility. So since all the individuals with streptococcal infection does not develop rheumatic fever, however, the identical twins, and when there is clustering of disease in the families, these are the hosts which are susceptible to develop the rheumatic fever and rheumatic heart diseases. And the third one is immunological evidences. It has been observed that the throat of patients during acute rheumatic fever may contain the streptococci. As we know, to every infection and towards every antigen, there is the production of antibodies by the body's immune system. So when there is streptococcal infection, there is production of antibodies against this bacteria, and the antibodies which are present in blood plasma in streptococcal infection, these are anti-streptolysin and anti-streptokinase antibodies, and these are important for the diagnosis of rheumatic heart disease and rheumatic fever. The second one, immunological evidence, is capsular identity, as the hyaluronate capsule which is present on the bacterial surface is also present in our joint tissues. So when there is same capsule right over there, so there will be confusion for our immune system, and it is one of the immunological evidence. Due to the presence of same capsule, so these are the target tissues for the attack. As we talked previously, that the rheumatic heart disease or the damage which is caused in streptococcal infection is not by the inflammation. The damage is caused by the immune reaction or the hypersensitivity. So how this hypersensitivity occurs, and this hypersensitivity only occurs in round about 3% of cases. For example, we take a host and it is got infected by the streptococcal infection, and towards this streptococcal infection there is autoimmune reaction. So what happens in autoimmune reaction? There is production of autoantibodies by the immune system. These autoantibodies cross-react with the streptococcal M protein. The problem is that the streptococcal M protein is totally identical to the M protein which is present on cardiac myocytes, or the same M protein which is present in actin, myosin and vimentin filaments. So the body recognizes body own cells and foreign cells, and bodies start killing and bodies start damaging the body own cells, and this condition is known as molecular mimicry. So when there is autoantibody and cross reactivity, so this causes damage to the tissues by cytokine mediated inflammatory response. So the damage which is caused in the rheumatic heart disease is due to the molecular mimicry, due to the M protein, because M protein which is present in streptococci is identical to the M protein which is present on cardiac valves and cardiac myocytes. This is known as molecular mimicry. Now we move on to next topic. So now we move on to the morphological features of rheumatic heart disease. So in rheumatic heart disease, there are two types of lesions. One is cardiac lesions and second one is extra cardiac lesions. So first we talk about the cardiac lesions. As we know, our heart is covered by the three layers, which is endocardium or pericardium, and the third one is myocardium. So in rheumatic heart disease, there is involvement of all three layers of the heart, which is known as pancarditis. So in rheumatic heart disease, there is no endocarditis, not pericarditis, or no myocarditis. There is presence of inflammation of all three layers, which is combined known as pancarditis. So first of all, we talk about the endocardium or endocarditis. As we know, the endocardium is the innermost layer of the heart. It is the innermost layer of the heart which covers the heart from the inner side. As we know, the heart consists of valves and also the cardiac myocytes. So in endocarditis, there is two types of lesions or two types of inflammation. One is valvular inflammation and second one is non-valvular inflammation. So first we talk about the valvular endocarditis. So in valvular endocarditis, there is thickening and loss of translucency of the valves, and the valve which is most commonly affected is the mitral valve, and it is of left heart. The left heart is more prone towards the rheumatic heart disease or the valvular infections due to the increase in mechanical stresses on the heart, and left heart is most commonly affected in most of the infections. So in valvular endocarditis, there is presence of multiple vegetations on the valve along the line of the closure. Mitral valve is most commonly affected, and in valvular endocarditis, let's say this is valve. So there is fibrous tissue vegetation like this, and this appears like fish mouth, and this is known as fish mouth stenosis of the mitral valve. So if we talk about its microscopy, the inflammation begins around the valve ring, and then it progresses to the entire valve, and at the end it covers even the free margin of the valve. So in valvular endocarditis there are two stages. One is acute stage and second one is chronic stage. In acute stage there is edema of the leaflet, increase in capillary permeability, and at that specific site there is increase in plasma cells, and there is presence of Escoffe bodies, which are the local areas of the fibrinoid necrosis. And the second difference which is there in acute stage is vegetations. If we talk about the microscopy of vegetations, it is eosinophilic. Eosinocytes is present right there, and this consists of fibrins with superimposed platelet thrombi. The second type of the valvular endocarditis is the chronic stage. In the chronic stage, the vegetations got organized, and there is diffuse thickening of the valve leaflets due to the presence of or the growth of fibrous tissue on the leaflets, and there is evidence of thick blood vessels right there. And the second type of inflammation is non-valvular inflammation. So the most important gross thing which is present in the non-valvular endocarditis is the McCollum's patch. What is McCollum's patch? It is a local area which is present, a local area which is rough, which is thick, and the wrinkled type of the muscles right there, and it is present on the posterior wall of left atrium and above the posterior leaflet of the mitral valve. So this is all about the endocarditis. Now the second one is myocarditis, and it is most important, and it is the most common of death due to the rheumatic heart disease. So the ventricle, or the part of the heart which is more prone towards the myocarditis, is the left ventricle. So in rheumatic heart disease, the left ventricle is soft and flabby, and there is small areas of necrosis right there in the left ventricle. And under the microscope, if we take the rheumatic heart disease slide, so there are Escoffe bodies which are seen. And what are Escoffe bodies? These are the areas of the fibrinoid necrosis which are scattered throughout the interstitium, and it is present even on the interventricular septum. And death due to the rheumatic heart disease is most commonly due to the myocarditis. So the last one in cardiac lesions is pericarditis, as it is the outermost covering of the heart. So pericarditis is the inflammation of the outermost covering of the heart. So what happens in pericarditis, that there is deposition of fibrin, and there is accumulation of fibrinous exudate in the pericardial sac, as the pericardium consists of two layers. One is parietal pericardium, and second one is visceral pericardium, and there is presence of pericardial fluid in that space. So in pericarditis, there is deposition of fibrinous exudate in the pericardial sac. So both periparietal and visceral pericardium resemble buttered surfaces of two slices in sandwich, and these are shaggy due to the presence of thick fibrin. So if there is no resolution of this fibrinous exudate, there will be fibrinous adhesions, and it can progress towards the adhesive pericarditis, and it ultimately compromises the contractility and the pumping ability of the heart. So if we talk about microscopy of the pericarditis, there is presence of plasma cells, lymphocytes, neutrophils, macrophages, and Ashkoff bodies in that and in that fibrinous exudate. So these are all about the cardiac lesions in rheumatic heart disease. Now we move on to the extracardiac lesions. The extracardiac lesions which are right there in rheumatic heart disease, number one is polyarthritis. What is polyarthritis? It is clear from the name that is acute and painful inflammation of the large joints, or it is inflammation of the synovial membranes of the joints. Sometimes it is also known as migratory polyarthritis because it affects larger joints, then it affects the smaller joints one after another. So there is proper sequence, and that's why it is known as migratory polyarthritis. The second one is in acute extracardiac lesions is subcutaneous nodules. There are painless collagen lumps under the skin surfaces in the rheumatic heart disease, and in most of the cases they remain unnoticed because they attach to the tendons, and these subcutaneous nodules are most commonly present on the extensor surfaces. The third one is erythema marginatum, and these are the rings-like rashes with central clearing and elevated red edges, and it is also migratory. Last one is Sydenham chorea. What is Sydenham chorea? It is the delayed manifestation of rheumatic fever, and in Sydenham chorea it involves the central nervous system, and in this there is rapid and involuntary movements of the face and most commonly the joints. So the presence of all these conditions: number one, carditis; number two, polyarthritis; number three, subcutaneous nodules; number four, erythema marginatum; and number five, Sydenham chorea. All these are known as Jones criteria, and it is major diagnostic criteria of the rheumatic fever and rheumatic heart disease. So if we talk about minor criteria of the rheumatic heart disease, the minor criteria include fever, arthralgia, joint pain, increase in WBCs, elevated erythrocyte sedimentation rate, increase in C-reactive proteins, and ECG changes with there is prolonged PR interval. So all these are the minor criteria for the diagnosis of rheumatic heart disease or rheumatic fever. And the most common supportive evidence in the minor criteria is the previous history or the previous evidence of streptococcal infection. We diagnose or we label a patient with rheumatic fever or rheumatic heart disease when there is two major or one major and two minor criteria. We label that patient with rheumatic fever or rheumatic heart disease. The treatment of rheumatic fever or rheumatic heart disease, number one is bed rest. Most of the cases of streptococcal infection can resolve on their own, and there is complete bed rest till the inflammation subsides. Second one is supportive therapy. For example, if there is fever, if there is a heart failure, we can support the patient. So second one is supportive therapy, for example, in the case of heart failure. The third one is antibacterial or anti-streptococcal therapy. Fourth one is anti-inflammatory therapy. We can give NSAIDs and other anti-inflammatory medicines to control the streptococcal produced inflammation. And the last one is, in severe inflammation, we can give the patient steroids to decrease the inflammation. Now at the end, we talk about the prognosis of the rheumatic heart disease. The prognosis is usually depend upon the degree of the damage, and if there is cardiac involvement, and if the cardiac involvement is in the initial stages, and if it is the first episode, it may resolve completely. So overall the prognosis is good. So at the end, sore throat can lead to the broken heart. So this is all about the rheumatic fever and rheumatic heart disease, and it is the most catchy topic and the most important topic for the general physicians. So this is all about rheumatic heart disease. See you in the next video. Subscribe to Medical Corner. Thank you.